So I'm very pleased to be here, and Anne's right. I've been really involved in MPN since I was a fellow, and I'm an administrator more than anything, but in my patient care, I really love taking care of folks with MPNs and with acute leukemias, and so that's where my clinical research is. And I also love educating. I like educating residents, fellows, and I do a lot of education in a peer situation, and I really love working with patients as well. So this has been an incredibly gratifying part of my career. So I'm going to talk a little bit as an overview, sort of the beginning of the day. Some of you may hear some of this again later, but really that's what teaching is about, is hearing it multiple times until it hits you. And I just want to also offer the fact that I'm happy to answer any particular questions that come up during the course of the day. So I want to start by just talking a little bit about how gender hasn't always been a well-studied part of how diseases and therapies work. And historically, women have been excluded from clinical trials. In fact, in the 1970s, the FDA said you can't put women of childbearing age on any clinical trials for early phase medications. And that was probably stemmed from the thalidomide experience of the 50s and early 60s, when European women were given thalidomide for pregnancy-related nausea, and only to find out that it was harmful to the fetus. And as the pendulum swung too far in the other direction, the institutions here in the United States excluded women from a lot of medical research. And what that means is they weren't picking up on some of the things that differ because of sex, in how a patient's blood readings might be, how a patient's disease progresses, whether or not they respond to treatments the same way that men do, how they metabolize, etc., surgical outcomes. So then in the early 1990s, Bernadine Healy was the first female director of the NIH, and she initiated something called the Women's Health Initiative, which really moved things back towards a greater sense of inclusion of women in clinical trials. And by 2013, so in that 15, 16 years or so, female enrollees comprised more than half of participants in NIH research. It is important to remember, however, that NIH research is not the bulk of research that's being done now. Much research now is being done by pharmaceutical companies interested in exploring the safety and efficacy of the drugs that are made. And we have a little bit less information, at least then, about the equity of enrollees in those trials. But there is a recent study that I looked at, and this is a complicated slide, but I'll just show you a little bit about how to interpret it. So over here on this left side are sort of groupings of clinical trial agents, whether or not a trial is being done in, for example, psychiatric problems, oncology problems, gastroenterology, dermatology, etc. And on the right-hand side, so you can't just say, is there an equal number of people getting, equal number of genders on a clinical trial? Because if the clinical trial is about prostate cancer, right, it's not going to be equal, because prostate cancer or breast cancer is not going to be equal. But on this side, what you can see is that the yellow dot is the number of, sort of the proportion of women affected by those conditions. And the black dot is the proportion of female enrollees on clinical trials. The farther away those are, the more misbalanced that is. And what we're thinking about here, when you look under oncologic, you can see, for example, that the black dot is to the left of the yellow dot. And that means that there's still too few women being enrolled in clinical trials to be proportional to their effect on it. Now, so what? Well, what I'm telling you here is that one of the take-homes of this is, if you have the opportunity to explore a clinical trial, that's something that will add to the information that we have. And the second point I'm making here is that we still have ways to go to make sure that what we are actually prescribing to people has been tested in the people that matter. And so that's just part of where our community needs to go. So what do we know about the influence of sex or gender? And I understand that that word isn't always the same thing. I'm going to be talking about biological females when I speak about females here. We know that males in general have a higher incidence of cancer. They have a higher incidence of what we call chronic myeloid diseases, which include the MPNs. And that in particular, we know that in these MPN, MDS overlap syndromes, which are a little bit different than MPNs, but that men tend to have worse overall outcomes and higher rates of leukemic transformation. And we think that that may be an interaction with lung cancer or an interaction with smoking, because we do know that smoking makes all of these diseases worse, and we know historically men have smoked at higher rates than women. So again, we are biased by what's happened historically. And when we look at new cases, male and female, you can see that there is a slight difference, and that's not just for MPNs, that's any leukemia that we know. So what about in MPNs? We do know that there are some differences in the way women go through MPNs in their life as men. That tends to be a little bit different at the age at which they are diagnosed. There tends to be slightly different chances of having thrombosis and where those thromboses happen. When I say thrombosis, I mean blood clots. There tends to be slightly different symptoms and a different balance of what we call clonal expansion. Again, perhaps because men have a higher risk of cardiovascular risk factors and smoking and higher cholesterol, which may change the way the disease behaves over time. So when we look at, again, this is a relatively complicated story here, but in their 30, 25 to 50s, more women are being diagnosed with MPNs than men. You can see that there's sort of higher rates of those of all MPNs, and then also essential thrombocythemia. Once you reach into the 50s, more men are being diagnosed with women, although these bars are not, it's not like 100%. There just shows you that balance. So there's some reasons behind this. First off, women are much more likely to see physicians and get their blood checked in their earlier years. That's because they're pregnant and they happen to get blood tests, and because historically, at least in the US, women are much more likely to go to doctors. And so that may explain in these earlier decades of life why women are more likely to be diagnosed. The second thing that you can think of is that essential thrombocytosis, which is a high platelet count, is more likely to be diagnosed here. And that doesn't mean necessarily that all those women have essential thrombocytosis, but MPNs, if you're bleeding every month, right? If you're having basically your body's doing its own phlebotomy every month, ET may appear to be the case when really polycythemia vera is the case. And so sometimes women will say to me, well, I used to have ET and now they're telling me I have polycythemia vera. And one of the reasons is, well, first off, diagnostics have changed, but also over time, and when you stop menstruating, you stop losing blood on a regular basis. And what you really notice then is that the baseline hemoglobin is a little higher. So that is one thing that accounts for the fact that over time, some women can have their disease basically be represented on a different part of the MPN spectrum. So we know that younger patients with polycythemia vera are more likely to be female. Of those younger patients, we know that in children, pediatric essential thrombocythemia and pediatric polycythemia vera also more likely to be female. And we know that when people have essential thrombocythemia with the JAK2 mutation, they're also more likely to be female. So those are some of the things that have panned out when we look at statistics. Women are also more likely to have a larger spleen when they present, and they're more likely to have this condition called masked erythrocytosis, which means having had a clot in their either stomach or liver, sometimes their spleen, and have normal hemoglobin, sometimes because of the clot, sometimes because, as I mentioned, menstruation. but still have a JAK2 positivity. And women are also more likely to present with blood clots in the liver, which can sometimes result in splenomegaly. We also know that the symptom burden differs, and this is work that was initially done by Dr. Ruben Mesa, who is really one of the most important people in this field because he was the one who began really systematically and in a validated way looking at the quality of life and the symptoms of patients with polycythemia vera, ET, and myelofibrosis, and asking in a very rigorous way what those symptoms are. And he and some of his colleagues hypothesized that gender influences the way these diseases are experienced by the patient, and that played out. We see here that women are more likely to have fatigue, they're more likely to have abdominal pain or discomfort, they're more likely to have headache, dizziness, numbness, and insomnia. So when they looked at these large numbers of people, again, more than 1,000 people, or more than 2,000 people with these conditions, they found that those are the ones that are more likely to affect women and may be more likely to bring them to a physician, and certainly the kind of things we need to keep track of and hope our interventions can help manage. So what are the take-home points? Men may have more aggressive disease when we designate that as more likely to become acute leukemia. Men may have worse survival, and there's a higher transformation to myelofibrosis in men historically. That doesn't mean the disease is differently, but it may mean that there's something else that's in the cocktail that's making men have slightly worse off. Women are younger at diagnosis. They're more likely to be diagnosed with essential thrombocythemia than PV. They may have worse symptoms, and they have a higher incidence of vascular complications. Now that's what we know so far. I will point out, and this is something you should think about every time you think of a clinical trial, every time somebody gives you a prognosis. These are general statistics. These don't speak to you in particular, right? These are what trends look like, or what, if you looked at 2,000 people, these are generalizations. But always remember that you are an individual, and your future is not prophesied, there's no prophecy here. This is just general ideas. So what are some common questions that arise in female patients? One of the most common that I get, especially with some of my with my younger patients, is whether or not hormonal contraception is safe. And that becomes especially important now that reproductive health is under scrutiny in this country, as we all know. Now we know that ET is the most common MPN in fertile women, and we also know that essential thrombocythemia and polycythemia vera give you a state of hypercoagulability, meaning much more likely to have blood clots. Some of those blood clots can be dangerous. They can be in the blood vessels of the brain, they can be in the blood vessels of the liver, the lungs, or in the heart. And even without having an MPN, being on the pill or hormonal contraception gives you those risks. So we recommend that these kind of things be very carefully discussed, and in my patients, I do not allow, or I don't, it's not that I don't allow, they can do what they want, but I recommend against hormonal contraception because of that increased risk of blood clots. We do know that there's a clinical trial of this. It was retrospective, but it looked at more than 300 patients with ET who were also on oral contraceptives. About a quarter of the ones who used both had a venous thrombosis, whereas about 7% of those who had EP who were not ET, who were not on oral contraceptives, had a clot. Now that makes a big difference, right? Because as soon as somebody has a blood clot, they move into what's called the high risk category. So that means for the rest of their life, they have to be on anticoagulation and cytoreduction. So anything I can possibly do to prevent people from acquiring that risk, that historical risk, is going to make a big difference in their future. And that's something I need to talk to them about the minute we meet. How about pregnancy? Is that possible? Well, like I just talked about, pregnancy is also a state where you have a high coagulation risk. But luckily, with more and more information and more consideration of women women with myeloproliferative diseases, we do have some good guidelines. And I've had several patients, knock on wood, who've been able to carry successful pregnancies. And that's really good to know that this chronic disease doesn't need to prevent them from forming a family. So right now we do see that there is an increased risk of some problems, including miscarriage, bleeding, or maternal clotting events. But I want to point out, this is not compared to control. So a lot of these do happen in women without necessarily a chronic disease or a chronic blood cancer. Nevertheless, I generally tell people that there is likely a slight increased risk of difficulty with pregnancies, and that's one of the reasons they need to be planned in advance if possible. A meta-analysis from 2019 looked at more than 1,200 pregnancies with a live birth rate in patients with any kind of MPN, ET, PV, or rarely myelofibrosis, because that's unusual in the younger population, with some decrease in the live birth rate. Aspirin or interferon were considered to be helpful and increase the odds. Again, this is a retrospective look of a successful pregnancy. So before anybody gets pregnant, we want to do a risk assessment, make sure that we understand what their history looks like, and then you want to take a multidisciplinary approach. You want to get your high-risk OBs in there and talk with them. We even have a clinic at MCW that's a high-risk obstetric for any women that have had cancer of any kind. And this is a really nice kind of group discussion that we can have with myself, with the obstetrician, with the patient and her loved one to discuss what our options are, including using aspirin, heparin, or even something to reduce the blood counts before surgery, before conception, and then safe ones during conception. You want to make sure that we're getting them delivery and postpartum information, because most blood clots with pregnancy actually happen after delivery, and then information on breastfeeding. Now, in low-risk patients, we generally try not to intervene, and when we can, we just use phlebotomies. It turns out with pregnancies, people's blood counts go down anyway because their total blood volume goes up a bit. Aspirin is generally safe, and we just have to make sure that postpartum people are on low molecular weight heparin to prevent blood clots. In high-risk patients, I try and get people off of Hydrea or anagrelide before conception. It's not always possible. Hydrea is likely contraindicated in the early parts of pregnancy. However, because it's used in lots of other medical conditions, including sickle cell, it's not like it's guaranteed that there's going to be some problem with the fetus if Hydrea was on board. It's just not necessarily optimal. We do use interferon alpha, that it's likely safe, although the pegylated interferon alphas may not be safe in early pregnancy. Again, that may mean we need to pause therapies for that early part of pregnancy. And then you want to prevent clotting, as I talked about, which is frankly the #1 risk, maternal risk, in pregnancies for people with polycythemia vera or ET. Now, what about as you age? How can you keep yourself healthy? So we know that as you move through your later reproductive years into menopause and menopause, there are changes that go through that have nothing to do with a blood cancer, but are just normal. And those include, for example, a shortening of your menstrual cycles, infertility. As you move into perimenopausal, you can have vasomotor symptoms, which sometimes can have overlap with what we typically think of with ETs, things like hot flushes or fatigue at strange times of the day. And then as you get older, urogenital atrophy or vasomotor symptoms can occur as well. So these are normal, healthy part of aging, and they don't always indicate that there's something wrong with or that the disease is getting worse. I want to make the point that hot flashes are different than night sweats. And hot flashes are really related to the genetics, your own genetics. They tend to be worse in individuals where there's some increase in weight or BMI. It's worse with smoking or less exercise. When I ask patients about night sweats, though, night sweats are a sign that the disease is transforming into something more aggressive, and is not always the case, but often a reason to look a little bit deeper at the blood cancer. And Night sweats mean really that people are waking up at night soaked, right? The kind of thing you have to wring your pajamas out. And that's not the same as a hot flash. So that should be easy to delineate. In terms of depressive symptoms, depression can also accompany this time of life for many people. This is a time of life when their family structures may be changing, kids going away to college, their self-definitions are different as they move from a space of maternal activity to one where they're redefining themselves. And it can also go along with being diagnosed with a chronic blood condition, which has scary attributes. So really we recommend therapy is extremely helpful for so many reasons. Cognitive behavioral therapy has been especially helpful in women going through menopause, and antidepressants can be helpful in many of the changes that happen. It's important to remember that depression is not a weakness. Depression is a disease. It's like getting a cellulitis. You take antibiotics and it gets better. And luckily, in today's day and age, depression is one of the most treatable, manageable diseases that we have. Sleep disturbances. So sleep disturbances are very common both with perimenopause and menopause. There is lots of recommendations about sleep hygiene, but another thing to think about is not get upset about sleep disturbances, to just recognize that over time, lots of people have managed this, and it's probably better managed with behavioral interventions than with medications. And finally, vaginal dryness or changes to sexual function. Unlike taking oral contraceptions or taking hormone replacement therapies, local estrogen therapy has a lot less systemic absorption. And in general, I tell my patients that that probably doesn't significantly increase the rate of blood clots. And if this is something that's really getting in the way of the quality of life, this is something that I will absolutely talk with my patients about. Another thing to keep in mind as you age is your heart function and the risks to blood clots in those vessels that feed the heart, those arteries that feed the heart, which are the most important arteries, among the most important arteries to keep open, because if they get blocked, then you can have a heart attack. And so one of the things to keep in mind is you have to monitor your heart risk. So I can send you guys this link. This is online. You can just look it up. And it allows you to calculate your heart risk. What's the likelihood of having a heart attack or stroke over the course of the next 10 years using some very basic information: your age, your race, your cholesterol, your blood pressure, whether or not you have diabetes, and whether or not you smoke. Now, these don't take into account whether or not you have an MPN, which we think would add into that. But this just gives you a baseline, and it's the kind of thing that you should keep an eye on, because there are things in here you can control. You can control your cholesterol, you can control your blood pressure, you can control your smoking. To some extent, you can get diabetes under control, although it's a little bit more difficult. So where you can control things, you should, because driving down that baseline means that the MPN will have less of a stepladder up to give you a risk for heart disease. So what are our targets? A complete abstinence from smoking, a heart-healthy eating pattern. That doesn't necessarily mean you need to be a vegetarian, but it does mean you need to choose high-nutrient foods. You want to avoid, where possible, high cholesterol foods, high fatty acids, and in general, we know that the risk of diabetes goes up with high carbohydrate diets. So be aware. I'm not a big one for like all or nothing diets, but I am somebody who recommends that you try and keep your body mass index between 18 and 24. There's a calculator online that you can use that just gives your height and your weight, and then it comes up with your body mass index, and you want to aim for between 18 and 24. And that doesn't mean that, I'm worried about being on the far end of the other side, so it just means you always just got to keep an eye on that. Keep your exercise up, eat a little less, keep in balance. And what we want to do again is just aim for that healthy weight category. A little harder as women get older because it's more difficult your ratio of muscle to fat goes away, and it's just harder to keep weight off. What about cholesterol? Well, you want to aim for a cholesterol that is higher on the good, which is HDL, and lower on the bad, which is LDL. The targets are complicated, but this is the kind of thing you want to talk with your PCP. And in general, Your cholesterol is largely guided by your genes. So while you can change a little bit of it with diet, mostly it comes from the genes that make up the way your liver functions. And so if you've tried diet, if you're at a good BMI, you may need to use a statin or something similar to lower your LDL. Exercise increases your HDL though, and dietary interventions can also help. Exercise, of course, 30 minutes, 5 to 7 times a week. Again, you don't have to be running a marathon, but there is almost no toxicity to regular, moderate, low impact exercise, and a lot of benefits. There's randomized studies that it drives down your blood pressure, randomized studies that it can improve your cholesterol, randomized studies that it decreases depression, randomized studies that it decreases stress, randomized studies that it decreases Alzheimer's. So if you need me to go on, I will, but generally, people benefit from this. It often costs next to nothing, and it's much better to do it early than late. Now, there is a slightly increased risk of other cancers for people with myeloproliferative neoplasms. They're about 4 times as more likely to acquire a lymphoma-type disease, which sounds scary until you realize that lymphoma-type diseases are also pretty rare. So if you're going from a risk of 0.2 to a risk of 0.8, that's 4 times, but it's still not something that you should lose sleep about it. There's a slight increase in the risk of solid tumors in patients with MPNs, thyroid, parathyroid. The one disease I worry the most about is skin cancers, and that's because hydroxyurea, for example, can increase the risk of skin cancers, and there is maybe an increased risk of certain skin cancers or other cancers with immunosuppressive therapies, and ruxolitinib, for example, a JAK inhibitor, may slightly increase your immunosuppression. So what do we do about all that? Well, we, again, do what we can. No tobacco, good sun protection, etc. And then make sure that you're up to date on your age-specific cancer screenings, prostate pap smears, colonoscopies, mammograms. If you've been a smoker for, I think it's 10 years in your past, sometimes a low-dose CT scan is recommended. You can ask your primary care doctor about that. But in general, talk to your primary care doctor and see what is recommended. Now, one of the things I want to also just talk about is collaboration between doctors, and that's because I think a lack of communication is the #1 medical error that happens. And communication is really crucial, and you can facilitate that. You can keep your own records and bring them back and forth. You can make sure that your doctors are sharing an EMR. One of the things that Anne has done, which I think is great, is just provide little cards where you can put the numbers of your doctors, make Xeroxes and hand them to them. One of the things I like to do is give my patients my cell phone, not so that they use it so much as so that they give it to their other doctors and have their other doctors call me when they need a dental procedure or they have their gallbladder taken out. I'd like them to reach out to me so I can give them advice on how to take care of this patient. I also want you guys to think about being in clinical trials. Clinical trials are generally in this middle phase where we're looking at, are there new medicines that really work? And as we talked about at the beginning of this, having more women in these clinical trials will mean that their results are more approachable and applicable to the women who need them. And each of these new interventions is tested at a given stage. Is the pill safe for humans? Is it safe in people with a specific cancer? What's the right dose? If you take it and you have myelofibrosis, are there responses? Are there toxicities? And does this work better than the current standard of care? And those are the types of studies: an early phase trial, a phase 1 trial, a phase 2 trial, a phase 3 trial. And these are what they generally are. And you can participate in any of these if they're available to you and if there seems to be a reason for you. And so one of the things to ask your doctor is, what kind of clinical trials are available here, and should I be looking at them? And any of these trials should be considered, but they're not always the best reason to do. If there's something that's a really good standard of care, you don't want to be doing an experimental medicine, something that has a very small chance of working, when you could do one that has a good chance of working. And you're going through those enrollment criteria will be important before you do any clinical trial. So I'm going to conclude. control what you can, ask questions, get involved, and focus on your personhood. This is a long road, and you're not alone. Thank you.
Questions for Dr. Michaelis at this point, although she will answer many after the morning session. Anything at this time?
Well, I wrote
That's okay.
okay. What I wanted to know is, regarding blood clots, I was just wondering, does it depend on the type of mutation you have and the percentage, the greater the percentage? I mean, I started off with 20% of a JAK2 mutation. It's down to 1%. And I'm just wondering, does that play a part?
So great question, and it's not really known we do know that having a JAK2 mutation versus having, for example, the CALR mutation or having an MPL mutation, having a JAK2 mutation does have an increased risk of blood clots, and that's most people, 98% of people with PV have a JAK mutation, and about 50% of people with ET have it. So we do know that that has an increased risk of blood clots. Right now, the jury's still out on whether or not decreasing your allelic burden is sufficient to decrease it makes a sort of one-to-one relationship with your clotting risk. And the reason that we don't know that is because most of the people that are on a medication to lower that has the consequence of lowering their allelic burden are what we call cytoreduced, and so the incidence of clots in people that are cytoreduced is much lower anyway. So it's hard to measure that. That being said, we're learning more and more about the long-term consequences of reducing that allele burden, and so I would say that we will be finding out probably in the next 2 to 5 years what the consequences are of that. It's likely not bad at all to do that. So I think that it doesn't mean your risk goes away. It doesn't mean you can stop anticoagulation at this point. I'm hoping that over time we learn that if that allele burden goes down, it will mean we can back off medicines, which will be for everybody's benefit.
Any other questions at this time?
Hello? Can you hear me?
I can.
If I have an MPN doctor already, is that enough to make sure I'm considered for trials, or are there other things I should be doing in addition?
Yeah, so that's a great idea. So a couple of things. First off, many people with MPNs don't necessarily need to be in a trial, right? They're in a standard of care thing right now. It's working well. Things are fine. So first off, it's not necessary. But it is the kind of question that should be readdressed every once in a while. And certainly, if your disease tends to take a left turn somewhere, if all of a sudden you've been fine and now you're waking up with night sweats, that's the kind of time when you need to, hey doctor, do we need to reevaluate where things are? This is a new symptom. What does this mean? And when things have taken a left turn, is there a new clinical trial I should be looking at? Let's say I'm on a medicine that's working really well and then it stops working. Well, that's a time to look for a clinical trial as well. And sometimes there are clinical trials that aren't necessarily about new medicines, but about some other intervention. Does yoga work to improve fatigue? Is there a over-the-counter supplement I might take that could help me with this itching? Those kind of things. If you're interested in that, you should first off ask your doctor. Second off, contact groups like Anne's group, where she has access to a lot of information about clinical trials. And then there's something called clinicaltrials.gov, and that you can go in there. It's any clinical trial in the world has to be registered with clinicaltrials.gov. You type in myelofibrosis or you type in essential thrombocythemia, you click on the recruiting thing, and it'll list all the ET trials that are currently recruiting and where they're open. And so you can ask your doctor about those as well.
Can I interject something here? So we did a survey recently of who takes that information to whom. And what we discovered was it was the patient taking it to the physician. And so, that very often the average hematologist could very well meet the criteria. Can everybody hear me? To be in a trial, but the patient is taking the information so we need to be better about educating the docs as well.
Which information are you speaking of when you say the patient
The clinical trial information.
Whether or not there's a clinical trial.
I read about this
Or
trial.
they were at an event, or they were on a webinar, or because we try to include our industry partners at everything to talk about the different topics.
One of the things that really also has been a transformative thing in a lot of cancer over the course of the last 20 years, I would say, is the role of patient groups like this one in peer-to-peer education and providing a separate warehouse for information. So the MPN Research Foundation, the Leukemia and Lymphoma Society, MPN Education and Advocacy International, all of those groups have places and sources to look and say, I have MF, is there a clinical trial I should be thinking about? And so you can hear about those and go back to your doctor. You can hear about those and set up a consultation with a doctor who happens to be listed on those trials. It's a dynamic and changing thing, but it's really because of the work you guys have been doing that bidirectional communication has really improved. No problem. All right, I think I've used up more than my share of time, so I will be happy to answer questions a little bit more, but for lunch. Thanks.